Morning, friends. I, at the outset, thank Dr. Jayakrishnan and the Trivandrum OBGYN team for this wonderful conference and inviting me year after year to discuss fetal medicine. So after listening to a lot of effort being put in to conceive that embryo and that fetus, we do realize that many of these women are of high maternal age, have had previous pregnancy failures, and we now need to offer them good antenatal screening to see whether we can pick up any abnormalities in these very high-risk group of people. And it's almost now 20 years since first trimester screening has started across the globe. Of course, in India, it's a recent concept. And in many Western countries, almost 90% of women get first trimester screening. So I thought it appropriate to talk on how to improve methods of screening. Of course, we have to establish yet that every woman has to get screening. But if you're already doing first trimester screening, what are the fallacies? How do we improve screening? So as you know, screening tests are to differentiate affected from non-affected individuals, and we are dealing with a trade-off between the detection rate and the false positive rate that, of screening that always will come in. So who is at risk? Is it traditionally, as we know, the high maternal age woman? We know that in that particular selected group, we picked up only about 50%. The detection rate was only 50% of Down syndrome, and we would miss 50% of Down syndrome, and with a very high false positive rate of almost about 18 to 20%. So it has been shown that all pregnancies are at risk in disregard to age, and we need to find that a patient who's having aneuploidy, and we cannot alone rely on the maternal age. As you see here, the maternal age would pick up only about 50%, and we would require more than 89 invasive tests at the 18-week age to pick up one case of Down syndrome versus about 16 invasive tests, so lower number of tests at the 12 weeks, and that's why the first trimester screening was really important, and it was a new window to look for aneuploidies. And it was greatly aided by the research that is continuously being done at the Fetal Medicine Foundation. So why is the first trimester scan so important? Because now we are actually personalizing fetal care to the fetus and to the mother. We are telling her in a very personalized fashion what is her risk of having an abnormality. And this can be best done at the 11 to 12 weeks. But important is that it is best done by qualified ultrasonographers. So you've got to have very good training to do this test, and we'll see why. And the second most important thing, which very much lacks in our country, is undergo regular quality assessment. And this is probably the beginning of this thought process of how to improve screening, is how to improve quality assessment. And as I said earlier, fetal care is now becoming personalized. The moment you look at the NT and you've got an NT of about 6.5 millimeters, we can tell the woman that she is having a 65% risk of having Down syndrome or any other aneuploidy for that matter. So it's very personalized. You have to carefully look at the fetus, carefully look at the nuchal scan, and then give a personalized risk to the mother. It's also important to realize that not only nuchal is correlating to abnormal aneuploidies, but it also tells us about unexplained fetal death can happen in about 20% of fetuses with an abnormal NT. As you can see here in this graph, the unexplained fetal death increases with the increase in NT. Also, the added advantage of knowing that there could be cardiac defects which increases with the increasing NT, and major abnormalities which may manifest a little later, but also about 45%, and some genetic syndrome. So whole spectrum of abnormalities that can be picked up by just one NT image as we see it here in the center. So it's very important that we do this NT very carefully, because you're personalizing, you're giving information, you're giving risk estimation, and then you're doing an invasive test to either confirm or rule out an abnormality. So as you see in this chart, we always use maternal history as a priority risk, And it's important to confirm that whether the maternal age is correct, because many times you may get the history written by your technician and it may not be correct. So it's very important that you ask the age on your own. You also look for the donor's age, especially when you're looking at an IVF situation. Many times we are having a donor egg, so it's very important that you look at that. The biophysical markers are, of course, the NT, which I'll talk about, and the third contributor to the adjusted risk, which happens following the combined test, is the biochemical markers, which comes with the free beta HCG and the PAPE. Now, with the biochemical markers in the Western context, the laboratories are very well established to do their quality assurance checks. And there is no emotion involved in doing those tests. So the machine gives you a result and you put those results in this algorithm and you get an adjusted risk. In our context, we are not very sure because of the differences, so many labs giving us varied results and probably no quality assurance. We have to rely a lot on the biophysical markers to establish that our results are of utmost quality. Not to say that we must insist on periodic checks on our biochemical labs. So probably try and use the same labs, analyze your results and see whether the lab is giving us good output and whether the results are verified. If not, then you have to see and talk to your laboratory people whether the methods that they are using or the quality checks that they are using are appropriate or not. So as you see here, in the combined test, there is no significant correlation between the biochemistry and NT. They are independent parameters added together to give us a detection rate of almost about 90% with the false positive about 5%. So this is as good as it gets today, and this is what we are doing. But if you see here in this chart with trisomy 21, trisomy 18, and 13, the medians are different for all the three aneuploidies. So this needs to be remembered that when you're dealing with a different population, different geography, your medians can be different from the Western medians. And as of now, we are using Western charts, Western information, because we don't have our detection or incidence of Down syndrome very carefully fed into the data of the aneuploidy screening. And herein comes the factor that you need to use MOMS to standardize the NT measurements. So you don't rely on individual NT measurements. You've got to measure that NT, put it in the software provided by the Fetal Medicine Foundation, do a risk estimation, and only then counsel the patient before you take any decisions on invasive testing. So you don't take a fixed cutoff of 3 or 4 and do invasive testing. And you must use this software, which is available free on the net from the Fetal Medicine Foundation. And it also corrects for the Asian counterpart. As we know, with the nasal bone, etc., there are a lot of variations which occur in the Asian population. So if you see here, the ethnic group is Asian. So this is a very, very important first step after you measure the NT to go into the software, put the measurements, and get the correct risk estimation. To do that, you need to do a very standardized technique, and as we know, this needs to be followed. You have no shortcut in this. The NT measurement has to be done in this fashion. You have to do it only between 45 and 84 CRL. You can use both transabdominal and transvaginal screening. It doesn't matter. In difficult cases, you can use transvaginal. But probably what's most important is magnification. It has been described over years of research that this is the only method to do it, and please do not include the entire fetus. You have to have only the head, neck, and thorax, and to see the perfect mid-sagittal section where you see the diencephalon, you see the nasal bone separate from the skin tip, you see the palate as a quadrangular area here. You don't see any bony tissue between the nasal bone and the palate, and that's when you measure the maximum lucency of the subcutaneous space as the NT. Now these are important images which I have added to tell you how not to get confused and fooled. For example, if the fetus is lying in this position, you may measure this as the NT because that's the amniotic membrane, as you see here. So it's very important at one stage of your measurement, you see the fetus moving up away from the amnion, and don't erroneously measure this as the NT. So it's important that you take multiple measurements and at least one after the fetus has moved. The other important thing, as we know, is that we never measure the fetus in either the flexed or the extended position, as you can see here, because it will alter the measurement in a great degree. And you have to have a neutral position of the fetus to have the perfect measurement. As I said earlier, magnification is very important. You see this fetus here, you're almost seeing the whole fetus, that's the NT, and that's just not the way to measure it. The same fetus, when it was magnified, you can see had an NT of about 3.7 millimeter. So this is exact proof of pudding that you must have the correct technique of measurement of the NT. When you have a nuchal cord here, you can measure above or below the cord to avoid compression by the nuchal cord, as you see here. Again, very important that you do not measure in the prone position. This is a fetus seen in the prone position. The measurement is 1.8, and when the fetus turns to a proper supine position, the measurement comes down to about 1.5. So these are very important steps to have a correct measurement of the NT. So what affects NT measurements? It is prone to operator variability, as I have just shown. So these steps have to be followed, and you require skilled operators. Once you're doing a properly skilled measurement, the factor that really affects measurement between observers is how you place the caliber. It's not the actual NT measurement, whether it's thick or thin, but it's the placement of the caliper which can affect the quality of the measurement. So you take the maximum lucency and you measure inner to inner is the correct way, and you take the maximum vertical measurement between the two lines. Sometimes you may get, it may appear widened in one area and narrow in the other area. You take the maximum measurement. You alter the gain. So the gain is very important, so that the gain is not very high. If you keep the gain settings very high, the lucency will become small. If you keep the gain settings very low, you may blur out the two lines which you measure it. So as I said here, you measure it the maximum lucency with appropriate settings. In order to overcome this deficiency sometimes of operator variability, many manufacturers have come out with auto NT, and this is probably a good way to begin with to train the students in the initial part. And what you do is just take a correct image of the NT. As you can see, the nasal bone diencephalon. This is a quadrangular palate. There is no nasal maxillary bone here. And you place a square in the NT area, and the machine will calibrate it automatically. And this is probably a good way to begin if you are not having adequate training to measure the NT. Once you have used these standardized techniques, you take at least 2 measurements and take the average to get a good quality of the NT measurements. It is very important to have sonographer and sonologist credentialing, and unfortunately we don't have that in our country. So it's good to use the FMF website, because the moment you put your images, they will tell you whether your images are correct or not and give you the license to do the NT. So it's very important that you do ongoing quality assessment, and year on year they will ask you for your images to continue your license so that you can have quality assurance. At this point, I must tell you that any swelling behind the neck, if it is thickened, is NT unless shown otherwise. In the earlier days, we used to consider this as cystic hygroma if it had septations, but now it is shown beyond doubt that all edema implications are the same, whether with or without septations. These are all having the same implications as the abnormal NT. And this was the protocol which Kipros prescribed from the year 2005. And he mentioned that any fetus with a risk of more than 1:100 should have a CVS, because that was the incidence of Downs. The intermediate range, that is 1:100 to 1:1000 risk, probably needs more markers to reclassify the risk. And if your risk is less than 1:1000, you just follow up with a 16-week scan. So it was important that this group of patients, which comes to about 15% of the population which is undergoing screening, will need further testing, and further testing can happen by other soft tissue markers, as I will just talk about. But before I talk about the soft tissue markers, I once again reiterate that when we are doing a combined test and we're using dual markers are affected by maternal characteristics. It's very important that you give the correct information to your lab that whether the mother is of high obesity, smoking, and whether the method of conception was natural or IVF. This is very, very important for them to give you a proper risk assessment. This brought out the Oscar Clinic in the year 2005, where you could do everything at one sitting. You do a biochemistry. Of course, it required a lot of investment to have equipment which gives you results of biochemistry within 30 minutes, and if the fetus is at high risk, do an NT scan and then do an invasive test. This is probably not feasible in our context because we have to rely on labs elsewhere. We have to send the sample, and you must know that the serum can get affected by the temperature in tropical climates. In fact, they are talking about now that the results validated with biochemistry, that is the 90% detection rate, was only valid for the Mediterranean and cold climate countries where biochemistry, specifically beta-HCG, did not get affected by the heat. In our context, with temperatures around 30-37 degrees, there is a possibility that if you store the sample for long or if you don't transfer the sample immediately, our results will not be appropriate in that fashion. So it's very important that the moment you do your biochemistry, the sample is sent to the lab immediately for analysis. The second thing in biochemistry which is very important is when to do the biochemistry. And if we have to improve the performance of nuchal screening, as you can see in this chart, PAPE is probably most sensitive at 9 weeks and beta-HCG is most sensitive at 13 weeks. And probably the best trade-off is to do everything at about 11 weeks because NT variability, as you can see here, between normal and abnormal is also maximum at about 11 weeks. So probably the best time to do an NT scan is NT, given the context that both PAPE and beta-HCG will have a good amount of variability. There could be other options. You could do biochemical testing at 9 weeks because PAPE is more sensitive, and if the fetus is at high risk, then do an ultrasound at 12 weeks. Probably not valid for our context. Probably the reverse may be true for us. We could do an NT scan first and then a biochemistry because NT scan is more freely available for us as compared to biochemistry. All this alteration of the timing of the biochemistry will improve the detection rate for about 5%. So from 90%, it improves the detection rate to 5%, provided you have the capacity of asking your patients to come twice, that is first for the biochemistry and second time for the nuchal scan at 12 weeks. Not very practical, so it's probably better that we do everything together at 11 weeks from our context. Then I spoke about the intermediate group patient, 1:100 to 1:1000, and how to tackle those patients. We have additional markers which Kipros has described, which again increases the detection rate from 90% to about 96%. And these markers are the nasal bone. At this point, again, you have to realize that it's technique. This is the nasal bone here, and you have to see the skin covering as a separate line and the skin tip as the separate line. The nasal bone should be the brightest line. If the brightness of this line is less than the skin tip, you have to consider it as a hypoplastic nasal bone. So this is very important that the same image which provides us with the NT, you have to very carefully see that the nasal bone is seen. For that, to do that, you have to have the transducer in a parallel direction to the nose. So this is the nasal bone here. Your transducer has to be parallel to this. So you have to get an image where you try and get the nasal bone in a horizontal fashion. And that's the time when you will get the best nasal bone image. You swing the transducer little to the left and little to the right from the basic NT image, and you will get the perfect nasal bone. And this is what an absence of the nasal bone looks like. So that's the presence of the nasal bone. And here you see the skin tip and you don't see the nasal bone. And this increases detection rate to almost 93 to 95% and reduces the false positive to about 3%, which was earlier about 5%. What we have to remember, of course, is ethnicity and geography, and we have known since the last years that we are doing this test, is that the nasal bone can be absent in 5% of normal Asian population. And so by itself, it is not a very strong marker in the Asian context, unless, of course, if there are other markers which are positive, like if the mother is of high maternal age, or if the biochemistry is suggesting a very high risk, or if the NT is high. So isolated nasal bone hypoplasia or agenesis, if the mother is of low maternal age and has good biochemistry, need not have any further testing, and that will be reflected in the risk estimation that comes in the moment you put in the ethnicity as Asian. But what's important is that the technique is very important. If you rotate, if you have the head in not a perfect mid-sagittal position, as you can see here, if there's even a 10% rotation, you will see that the nasal bone is seen, but you don't see the skin tip and the skin covering, so this is not the correct technique. And if you have a 15% rotation, you will actually make the presence of a normal bone appear like an absent nasal bone. So it's very important that you have a perfect mid-sagittal section, and all these additional markers will then be useful for that intermediate group of patients. The moment you have an absence of the nasal bone, the risk becomes again high, 1:100, and you have to give invasive testing. And so also for the ductus venosus, I'm going to rush through this now because of shortage of time. Again, technique very important. This is the ductus venosus, and very high sensitivity, almost 65% of picking up trisomy 21. Apart from that, also tells us about cardiac abnormalities, but it's important that you have the correct technique. This is not reversed A wave, this is superimposition of hepatic wave. So you've got to reduce the gauge size to about 0.5 to 0.7 mm to get the perfect ductus venosus. And here again, detection rate would be 95%, false positive 2.5 if you add it to the combined test results. Apart from aneuploidy, it also gives us high detection of cardiac disease. So if you've got a reversed A wave with an abnormal NT, this fetus has got a very high chance of having a cardiac abnormality. And so also for the tricuspid valve, you put the Doppler across the tricuspid valve, you increase the gate here to about 2 millimeters, and if the reversed flow in the Doppler parameters here is more than 1 meter or 60 centimeters per second, that suggests that there is tricuspid regurg, again indicating a high chance of aneuploidy and a cardiac risk. So this is just one case showing a tricuspid regurg, and the fetus had hypoplastic left heart manifested on a later scan. Small mentions about other small markers. Facial angle, you drop a line from the palate to the nose, and if this is a combination of two markers, or at least a combination of the maxilla here, we know that in Down syndrome the maxilla is hypoplastic, so the maxilla goes backward, and this angle will become obtuse. So anything more than 85 degrees at any stage of pregnancy is a high risk indicator of Down syndrome. As you can see here, abnormal nuchal, the maxilla is small, the angle is about 98 degrees. So again, the same nasal bone, ductus venosus, tricuspid valve, facial angle, all form part of this group where of 15% of the population of intermediate risk, which can be reclassified as high risk. And then there are a lot of other new soft tissue markers which Kipros is working on, like the hepatic artery Doppler, echogenic bowel in the first trimester, pyelectus in the first trimester, choroid plexus cyst in the first trimester, and probably we'll hear a lot more of that. Even the insertion of the ductus venosus directly into the IVC is an indicator of a new marker as Down syndrome. And finally, look for abnormalities, because as we know, the first trimester window is not only a window to look for NT and all the markers that we have just spoken for, but it's also a good window to look for abnormalities. Specifically here, you see holoprosencephaly, a Dandy-Walker malformation. You can see a diaphragmatic hernia here. You can see an AVSD, canal defect, cardiac defects, megacystis, and all these are high indicators that this fetus is having an aneuploidy situation, an omphalocele for that matter. It's also a good window to look for the spina bifida as described by Ravi Choi. So you look at the brainstem, the fourth ventricle, and the cisterna magna. These are the three lines, and if these lines are not well seen, or if the brainstem is widened, that's a good sign that it could indicate impending detection of spina bifida, and as it is called, the IT sign. So I will quickly rush through these because I'll go to the last few slides. So these images that were just here were fetuses with abnormalities, as I just showed you a few. And so coming to this slide, most countries across the globe who are using NT are doing a lot of quality assurance checks for all the users that are doing NT. Unfortunately, we don't have quality assurance checks we don't even have certification for our users doing NT. And also, as you see in this chart here, even their labs have quality assurance, so they calculate the moms, and if the moms are not fitting with what their regular moms should be, then they are giving feedback to their laboratories, and only then you can give a detection rate of as high as 95 to 97%. The last 2 or 3 slides is to inform about the new kid on the block, that is the NIPD, non-invasive prenatal testing, and this is going to change prenatal screening in a very, very big way. And as you can see here, the detection rate is almost as high as 92 to 99%, depending on which aneuploidy you're dealing with. So trisomy 21, almost 99%, trisomy 13, probably 92%, and this can be done from 9 weeks onwards. So you just take a mother's blood and you can give her a risk estimation. So what Kipros is now suggesting in 2014 is that instead of 1:100, which would get a CVS, the risk of patients who should be getting CVS has to be as high as 1:10. And the intermediate group, which was earlier 1:100 to 1:1000, is broadened from 1:10 to 1:2500. And this group can get NIPD, and that is the high performance screening test. And if it is positive, then again you go for CVS. If it is negative, then you go for 16-week scanning. In conclusion, screening, as we know now, should be offered to all women in the first trimester. The risk estimation, as we are dealing with combined screening at the moment, is 90% with the FPR of 5%, but with additional markers you can improve the screening performance, and that's possibly most important from our context because we are good at ultrasound. We can do a quality check on our ultrasound, we can improve our ultrasound technique, so we can do all the markers in one sitting and improve our detection rate. In high-risk groups, we have to give invasive testing, and this does require extra time and effort, and you should give that to the patient and do a regular audit and aim high and play safe when you're dealing with fetal medicine. Thank you very much for a patient hearing.